Let's go quickly to the next question. Choroidal melanoma is also a stock topic, but earlier simple questions used to be there, like choroidal melanoma, can it cause retinal detachment? Which, if so, is it tractional, is it exudative, kind of questions. Now examiner wants to know from you, what is the prognosis of choroidal melanoma? It is the size, the location, the transscleral extension, involvement of the Bruch's membrane, optic nerve extension, lack of pigmentation, increased vascularization, and the histological features showing the neoplastic features of the cell with the increased mitotic activity. They are all considered to be the signs of the bad prognosis. Retinal detachment is not included in this, is what need to be remembered. That's the reason, doctor. Cytology, size of the tumor, extraocular extension with the optic nerve extension, they are all considered to be important prognostic factors, but not the retinal detachment present or not in the prognosis is what need to be remembered. Let's go to the next question. In the beta thalassemia trait, which is a very important hemoglobin that is important, this is all basically first MBBS question, which you have to be sure by now. So typically if it is a beta thalassemia not major, minor, it is the hemoglobin A2 which is demonstrated by the electrophoresis is going to confirm the diagnosis of the beta thalassemia. A trait individual may not have florid symptomatology, but if you are suspecting a trait, get an electrophoresis of the hemoglobin. If it is showing predominance of HbA2, there you have to suspect the possibility of the beta thalassemia trait is what I want to underscore to all of you. I still remember one of our patients who had a thalassemia major and admitted with us, and one of my own colleague, rather a junior who was also doing post-graduation, said, there is a similar kind of history of consanguinity in his parents. I also have consanguinity, but I am not having thalassemia. Then in a jovial manner we said, then go and check your hemoglobin, you may be having beta thalassemia trait. And he checked his, really sent to Apollo Hospital the electrophoresis, and it turned out to be HbA2 predominant. Then he went through all the literature, medical libraries and all that. We said, don't become insane. You need not worry. If we start detecting our whole body scanning and all that, some tumors, in textbook if one line applies to us, then our one life is gone. So is it not that suddenly if there is a small testicular displacement or an ovarian necrosis, some statement of textbook applies, one statement is sufficient. So that is the reason, doctor, always a high index of suspicion is required is what I want to say. But there is one small pitfall for the beta thalassemia trait being diagnosed with HbA2 in Indian context. Suppose if iron deficiency is coexistent, then the hemoglobin A2 may not be observed until the iron is once more repleted is what I want to underscore, that caveat which you should not basically forget. Now can there be any more sensitive test for the thalassemia is my question to all of you. The free erythrocyte porphyrin is one important test because microcytic hypochromic anemia can be a feature of both iron deficiency individual and also an individual who has got a thalassemia. How to differentiate that it is not due to iron deficiency but because of the thalassemia? You try to check for these free erythrocyte porphyrin levels. Typically it will be normal in the case of the beta thalassemia, but it will be elevated in the case of the iron deficiency and lead poisoning, the two important conditions which you should not basically forget. Why it become elevated, doctor? If the iron is not there, protoporphyrin, Miss protoporphyrin cannot become Mrs. hemoglobin. So it remains as a virgin for longer time. So that's the reason free erythroprotoporphyrin levels become elevated is what need to be basically remembered. Let's go to the next question. For the antenatal diagnosis, you take the maternal serum but not maternal urine. So that's the reason D is the answer, all of you know very well. Next question, human papilloma virus, all of you know, leads to a lot of tumors, even in the humans also. That's the reason B is the answer. It's a false statement, not in humans. In fact, you have the warts, epidermodysplasia, varicosa, squamous cell carcinomas, laryngeal carcinomas, and bovinoid papillosis, malignant vulvar lesions. N number of diseases, big list is there related to HPV. That's the reason it causes. Now, which causes the problem in the sex chromosome? All of you know it is a Klinefelter syndrome and the Turner syndrome, super female. They're all the examples of the sex chromosomes. Now a very important question we have arrived. Hodgkin's lymphoma, one of our Murphy's law. Without lymphoma and leukemia, examiner is not doing his job in setting a paper. So that way, doctor, Totally there are about 300 to 400 topics. Now let us talk about it. All of you know the best prognosis is there typically for a nodular variety. So there is a reason, doctor, the nodular has a worse prognosis than diffuse is a very much, at a glimpse only you can decide it's a wrong statement. But anyway, the other things are also very, very important. So what is the prognostic scoring which you will be using in the case of the malignancy, that is a Hodgkin's, in the lymphoma? The age of the patient, the performance scale, and the LDH level, and more than one extranodal site in stage 3 and 4 disease, they all carry a bad prognosis is very, very important in relation to the lymphomas is what I want to underscore. Let's go to the next question. Regarding interstitial lung disease, the question is, can smoking can predispose or not is a very important question. Interstitial lung disease is a very big topic. There are different varieties of interstitial lung disease. You need to basically remember, doctor, there are some intrinsic lung diseases, extrinsic lung diseases which can finally express and declare themselves as the interstitial lung disease. Collagen vascular diseases and similarly conditions like pulmonary vasculitis, eosinophilic pneumonia, bleomycin like drugs, cyclophosphamide, methotrexate, radiation, gold, emidaron, nitrofurantoin, they all can lead to the development of the interstitial lung disease is something which you should not forget. Similarly, inorganic dust exposure like the silicosis, berylliosis, Kohlwerker, pneumoconiosis is very important, and organic dust exposure like begasosis also can lead to the development of the interstitial lung disease. And if there is a smoking history, especially the interstitial pulmonary fibrosis, idiopathic pulmonary fibrosis, desquamative interstitial pneumonitis called DIP is a variety of interstitial pneumonia, bronchiolitis obliterans, they all are predisposed in a smoking individual. So there is a reason, doctor, tobacco smoke, inorganic dust, organic dust, everything can cause. By exclusion you can consider C as a possible answer. Let's go to the next question. Patient has a rise of neutrophil, basophil, eosinophil, platelet, everything, myeloproliferation is there in him. Now which is the myeloproliferative disease in this? It is a chronic myelogenous leukemia is what you can say. The patient is having thrombocytosis and typically the platelets are showing a lot of granularity. If you have done the bone marrow, it will show the megakaryocytic appearance. What is this condition? It's called essential thrombocythemia, where there can be a development of a granularity within the megakaryocyte. If you do the bone marrow, the presence of a megakaryocyte of a giant nature is a classical hallmark on bone marrow is what need to be remembered. And in essential thrombocytopenia, a sustained unexplained thrombocytosis is one of the important conditions. Suppose if the platelet count is about 5 lakhs or 6 lakhs in our Indian context, what is the common cause, doctor? Please check. Iron deficiency may be there, where reactive thrombocytosis can occur. If you have treated iron deficiency, platelet count is going to normalize. That you have to be doubly sure before placing a heavily labeled diagnosis of essential thrombocythemia. Patient has got a pathological fracture with a punched out appearance, and what do you expect? Typically in a 70-year-old man, high ESR with the presence of the fever. So without a question on multiple myeloma, plasmacytoma, there is no question paper which you have to be doubly sure. That's the reason in this given case of the plasmacytoma in the elderly individual, if you do bone marrow biopsy, greater than 30% of the bone marrow cellular population will be plasma cells is what need to be remembered. Let's go to the next question, which is not a B cell neoplasm. Once more, simple sweet question which will test the fundamental knowledge about the classification of the B cell neoplasms. Before we go to the answer, there is a small trick here which you have to be doubly sure. There is an angiocentric lymphoma and you have a lymphomatoid granulomatosis, otherwise called angiodestructive lymphoproliferative disease. There is a small difference between the two. This lymphomatoid granulomatosis is of an unknown etiology with a pulmonary involvement, where it will be looking like vaginous granuloma if you happen to check through the radiograph, and it is classified as a B cell lymphoma with a T cell reaction around that lymphoma. So this important variety called lymphomatoid granulomatosis is a B cell neoplasm. But on the contrast, you have another thing called angiocentric lymphoma, which is once more placed under the another important classification, not the B cell, is what need to be basically understood. So now let us quickly review, Doctor. B cell lymphoma classification of WHO, you have to be encyclopedic. Already we discussed in a great detail in pathology discussion, but anyway, you have lymphoblastic lymphoma and the precursor B cell acute lymphoblastic leukemia, otherwise called BALL, it is otherwise called. It is an example of B cell neoplasm arising from the precursor B cell. Then you have the B cells which are there in the periphery, no? From that the neoplasm can arise. So lymphoplasmacytic lymphoma, mantle cell lymphoma, follicular lymphoma, hairy cell leukemia, plasmacytoma, Burkitt's lymphoma, they are all the ones which are arising and they are called the peripheral B cell neoplasms. So that's the reason, Doctor, Burkitt cell lymphoma and the hairy cell leukemia, both of them come under the important group called B cell lymphomas is what need to be remembered. Similarly, mantle cell lymphoma is also placed under the group called B cell lymphoma basically. Then you have another important group called T cell lymphomas. Once more, they can arise from the precursor T cell or from the peripheral T cell or a NK cell. That is a broad classification. So mycosis fungoides, angioimmunoblastic T cell lymphoma typically is an example of a T cell lymphoma is what I want to underscore. So there is a reason, Doctor, the answer becomes the angiocentric lymphoma, which is of T cell origin, is what I want to underscore to all of you. Finally, you have the Hodgkin's lymphoma in that 4 varieties, all of you know. Nodular, lymphocyte rich, lymphocyte depleted, which has bad prognosis, and the mixed cellularity are the 4 important groups. Let's go to the next question. Red proto-oncogene typically is found in which important tumor? All of you already know your encyclopedic, Doctor. Medullary carcinoma of thyroid. Also remember, even in the MEN2A, that is a Sippel syndrome, where medullary thyroid carcinoma with the pheochromocytoma with the parathyroid hyperplasia are coexistent. Even in the case of the MEN2A also, you find the red proto-oncogene is what need to be remembered. Now let's go to the next question. Barrett's esophagus adenocarcinoma, all of you know, and warfarin and P450 system of the liver and cytochrome P450 system, inhibitors and promoters, stimulants. Invariably one question will come, any entrance you write. So please remember, Doctor, it is the amiodarone, cimetidine, phenylbutazone, these 3 you should not forget in relation to warfarin. Especially amiodarone you should not forget. Why? Because a patient who has got a mitral stenosis with the development of a left atrial dilatation, with the development of the atrial arrhythmias, you are giving amiodarone in order to take care of the atrial fibrillation, and you are giving warfarin in order to prevent the embolism. So this warfarin and amiodarone can interact with each other, which will lead to the development of the warfarin's anticoagulant effect become excessive, leading to the bleeding diathesis of the patient. Sometimes hemorrhagic stroke can occur. That's the reason you have to be doubly sure about amiodarone and warfarin. At least as a clinician, I need to remember about these 2. Of course, cimetidine and other things are academic sense, you need to remember. Fluorinated anesthetic, which will be corroding the metal in the vaporizer. These are all anesthesia is a stock topic, you have to be doubly sure. And which anesthetic, if you are administering, leads to pain, Doctor? Propofol, the daycare surgery anesthetic agent, nearly 30 to 90% of patients will develop the pain. Similarly, rise intracranial tension, ketamine, all these are like your name, hall ticket number, you must answer this kind of questions. Then which drug can cause renal tubular damage? Cisplatin is very much notorious to lead to tubular damage. Now a very important question. Imatinib is the modern agent that we are all using. What is the main method of functionality of imatinib? Basically, in the case of the chronic myeloid leukemia, CML, in fact after discovery of the imatinib, the whole story of CML has totally changed. Getting CML is like getting a fever. You start imatinib, patient will show wonderful improvement. Earlier days, all the other neoplastic agents which we are using with a massive spleen with a patient of CML, there was not much of hope, but imatinib totally changed the things dramatically. How does imatinib function? The problem in the case of the CML is this important combined gene called BCR-ABL. So it is this inhibition of this BCR-ABL by the imatinib which will be preventing the aberrant phosphorylation and preventing the downstream signal transduction and further neoplastic pleiotropic effects, inhibition of them is a mechanism. So there is a reason imatinib basically functions on the tyrosine kinase of the BCR-ABL. After BCR-ABL has fused, the product of them is a wonderful tyrosine kinase which will cause signal induction leading to the neoplastic proliferation. So if you can block that by giving the imatinib all the way at the level of BCR-ABL tyrosine kinase, you can prevent this EML. So I mean you can treat it. So that's the reason tyrosine kinase is the answer. Now which is the agent which is an aromatase inhibitor? We are all now in the era of letrozole. So what is the importance of the letrozole? It is a neoadjuvant endocrine therapy. The aromatase inhibitor letrozole along with the tamoxifen, if you basically administer it to a estrogen receptor positive breast cancer patient who is not a right candidate for mastectomy, giving the letrozole is a wonderful way by which you can manage the breast cancer, especially in an inoperable case. So that's the reason it is basically aromatase inhibitor is what you need to remember. Now which chemotherapeutic agent is associated with leukemia? So now you know importance of anti-neoplastic drugs in the pharmacology, which you have to revise today itself, doctor. So cisplatin. Now nitric oxide, can you use it in pulmonary hypertension? Sildenafil, can we use it? So sildenafil is a wonder drug not only in impotence but also in pulmonary hypertension as a pulmonary vasodilator is what you need to basically remember. Now what are the options available for managing a young lady presented to you with the shortness of breath, exertional dyspnea, a loud pulmonary second heart sound with a parasternal heave where you are suspecting pulmonary hypertension. You have ruled out the secondary causes for the pulmonary hypertension like a ventricular septal defect or atrial septal defect, and you also have ruled out any embolic phenomena leading to pulmonary hypertension, and it is a idiopathic pulmonary hypertension, a young female. What do you want to do for her? Sildenafil is considered to be one of the wonderful ways by which you can manage. Calcium channel blockers can also be used as a vasodilators is what I want to underscore to all of you. So in pulmonary hypertension, afterload reduction, digoxin therapy, diuretics, they are all very important part of the management. And among the vasodilators, calcium channel blockers, nifedipine, prostacyclin, nitric oxide, they are the three important drugs which you should not basically forget. Let's go to the next question. Regarding fentanyl, all of you know, after administering there came a development of a chest wall rigidity, one of the classical problems. Now vanilloid receptors, once more this is a what you call reincarnation question, doctor. So unless you are doubly sure, don't try to bid your answer when negative marking is prevalent. It is pain which is important. Basically it is the C fibers and A gamma fibers through which the vanilloid receptors will be projecting to the dorsal horn of the spinal cord, which is the gateway of the pain transmission. So vanilloids like capsaicin, they have got a biphasic action. A initial excitatory phase where pain will be there, followed by desensitization. So that's the reason vanilloid receptors are associated with the nociception associated with the thermal stimulus. When we touch a hot cooker, why we feel so painful? So thermal thermal stimulus associated nociception, vanilloid receptors are associated is what need to be remembered. Now let's go to the next question. REM sleep versus that of the wakefulness, what is the difference? What is the underlying physiological reason for cataplexy and narcolepsy, doctor? Suddenly why the patient will fall down with loss of the muscle tone in a patient who has got a cataplexy? The reason is the REM sleep will be intruding into his sleep cycle. So while he is at work, suddenly REM sleep will begin without any foreplay of NREM. So that's the reason he loses the tone and falls tone. That is the underlying problem in the case of the cataplexy. So now let us talk about the REM sleep and difference between that and wakefulness. There will be rapid saccadic movements, and there is one important there are some important centers in the brain which will initiate this REM sleep is what you need to basically understand. All the dreaming that we have is typically during the REM sleep, which is the lightest form of the sleep is what need to be remembered. Suppose if somebody is dreaming in REM sleep, he is there, if you wake him up and he wakes up, will he get a fresh sensation? Very much. In fact, the sleep where you dreamt is the one which is the most refreshing sleep is the golden rule which you should not forget. Both after the sleep and at the time of sleep. What is the reason? Because you have dreamt means you entered into REM, you have entered into REM means there is a muscle relaxation, there is a relaxation means when you wake up, it is like a Ayurvedic Kerala massage that you had is what need to be fundamentally remembered. And during the night, we have typically about 4 to 5 periods of this REM sleep. In the beginning of the night, whenever REM occurs, it is short, and towards the end part of our sleep, by about 4 or 5 o'clock when about the alarm is going to ring, REM will be little longer. Totally about 90 to 120 minutes of time is spent in the REM sleep. In a newborn case, he will have more opportunity to dream. About 80% of his sleep is REM mode, and 70-year-old man will be repenting for all the things happened throughout his life. Very less amount of dreaming about future of 170 years. He has to only be nostalgic and repenting. Average is only 20%. So if you take a polysomnographic recording, what you are seeing here is all this REM sleep, and during this REM sleep, the eye is showing a typical oscillations which are indicated over here. This is the rapid eye movement followed by a non-rapid phase is what you are able to clearly see. So physiologically, there are some important locations in brainstem. Remember, doctor, sleep physiology is one topic. Where do you find delta waves and all this? You have to master this topic today night itself, declaring the emergency, because you will not remember it before exam. Typically, certain neurons, especially in the pons, the tegmentum, the floor of the pons is the place where the REM sleep associated neurons will be functioning. And typically, certain important monoamines, the norepinephrine, serotonin and histamine, the release of them become completely shut off at the time of the REM sleep. So these neurotransmitters are all like our SMS and telephone calls, doctor. So they are shut down during the REM sleep so that you can happily dream about what you wanted to do in life. So because of the shutting down of this norepinephrine, serotonin and histamine, there is a sudden loss of the tone leading to the development of the atonia, which is the characteristic feature of the REM sleep. And generally, REM will not intrude into our life when we are awake in the morning. But the patients who have cataplexy, suddenly there is an entry of an REM sleep, they lose the tone, they fall on the floor and then they go into the sleep. So that is the underlying problem, is what you have to basically understand. In some people, there is an important dysfunction that though REM sleep has started, there is no shutting down of that neurotransmitters. That's the reason there is no atonia. So that is the reason what happens is, it's called a REM behavior disorder, where they will act out the movements which are occurring in their dreams. Suddenly they are having a jaw-breaking kiss of Miss World. They will try to act it out because there is no atonia which is happening while they are dreaming about it in the REM sleep, is what I want to underscore to all of you. Now, what are other physiological changes in REM sleep? The heart rate and breathing rate become irregular, and the body temperature is not well regulated. Sometimes it will approach the surrounding area just like a lizard, which is a not a poikilothermic animal. Erection of the penis and clitoris are also common during REM, but not characteristic, is what you have to basically remember. And all the eye movements or the rapid eye movement phase are because of the superior colliculus is the one which is regulating it, is what need to be remembered. So finally, at the end of all this story, doctor, you need to remember, it is the decreased muscle tone which is considered the clinical sign par excellence, is what need to be remembered. Let's quickly go to the next question. In the man, what is the large amount of zinc, where is it present? It is basically contributed by the prostate. You can easily remember, we give multivitamins, zinc, everything to elderly individual who has a prostatic hyperplasia. So prostate and zinc are unforgettable, is what need to be remembered. Now, follicular stimulating hormone versus LH, which acts on theca cell, which acts on granulosa cell. Invariably it is asked, because one question comes on the female reproductive cycle physiology, which you have to be doubly sure about. So basically FSH is the one, doctor, which is responsible for identifying who is the dominant follicle out of the multiple follicles which is going to ovulate and release the egg. Now for that, there are some FSH receptors which are located upon the granulosa cell, is what need to be understood. So LH stimulates the theca interstitial cells, FSH stimulates the granulosa, is the golden rule which should not be basically be forgotten. Let's go to the next question. After ovulation, how many days implantation will be occurring? About 7 to 9 days later. HCG is produced by trophoblastic cells. There you should not get doubt. Is it York-Sack? Is it Ultimate Institute of the Nation? How can they ask such simple questions? They can be simple, doctor. Even in that institute also, trophoblasts only should secrete HCG. Now, estrogen administration in the menopausal women increases the bone mass. That's the reason osteoporotic individuals, postmenopausal age, we are all promoting the estrogen supplementation. Uterine musculature is relaxed by the progesterone, stimulated by the estrogen, all of you know very well. Now, typically in the case of mammals, they are only seasonal breeders, unlike the humans who are 24/7 kind of functioning in their reproductive capability and libido. So that's the reason it's called estrous cycle is what need to be basically be understood. A patient who got an acute psychosis received a haloperidol, dystonia is there. So this is one of the favorite and routine questions which is asked in the exam. Now haloperidol, following that there is a rigidity, echinacea, mutism, sweating and increased blood pressure, then what is the possibility? All of you know, neuroleptic malignant syndrome. Which is the blood chemistry value which you want to check for doctor in a suspected case of neuroleptic malignant syndrome? CPK levels. CPK levels will be 1000, 1200, 1500, such a high level of CPK must supplement your diagnosis of the neuroleptic malignant syndrome.